Hi everyone, this is Sarah, pharmacist working on antifungal drug interactions database. Today we're looking at drug-drug interactions with the spotlight on amphotericin and echinocandins. I'm hoping by the end of this presentation you'll have an overview of the term drug interaction, understand how amphotericin and echinocandins work, and hopefully you'll have some skills in managing the interactions when patients are taking other drugs with amphotericin or echinocandins. We can class a drug-drug interaction as a reaction between two or more drugs. They can be prescribed or they can be non-prescription, they can be plant-based drugs. You can also get drug interactions between a drug and food, drinks, beverages, or even supplements. You do find a lot of patients buy stuff and take it themselves, not classing it as a medication, and then end up with perhaps treatment failure or drug reactions because of the interaction that happens between these. So just be mindful to ask patients about other supplements that they may buy themselves. So drug-drug interactions are one of the most commonest causes of adverse drug reactions. They can be classed into two main groups, one being pharmacokinetic and the other being pharmacodynamic. Pharmacokinetic involve things like absorption, distribution, metabolism, and excretion of the drug. Pharmacodynamic, which is what the effect the body has on that drug. They can affect, it can be to do with receptors. You can get failures at particular receptors. You can get interference with certain processes, and you can have an additive or an opposed pharmacological effect. So there's two separate components here. Now this can lead to altered drug effectiveness. It means the drug doesn't work as well, or you can get toxicity where the levels are so high that it's affecting that particular person and their body, and actually it's too much for them. When looking at severity of interactions, drugs like your azoles have a lot more severe interactions than ambisome and the echinocandins. This doesn't mean that they're any less of an issue. We just manage them, and the kind of interactions that perhaps are classed as severe for these drugs are a little bit different, and we'll talk about how and why the severe interactions do occur for these drugs compared to azoles. Amphotericin, as everybody knows, is not a new drug. It's quite an old one, in fact, with amphotericin deoxycholate actually first being licensed in 1959. However, the first study of nephrotoxicity didn't appear till around 1964. And with these toxicity issues, it was found there was a need for dose reduction. But then there was a problem with dosing, and this led to progressive infection and even perhaps therapeutic failure. So we weren't treating the fungal infections. In around the mid-80s, so around 1984, we had the first experiment using liposomal amphotericin. So a liposomal formulation which allowed amphotericin to be delivered in a lower dose, but reducing the toxicity, but not leading to the treatment failure. So in around the 1990s, we saw the first liposomal amphotericins get their license. Around the world, there are now many amphotericin preparations that are liposomal. Here are some of the listed preparations. We will talk about bioavailability in another slide, but it is really important to know that it's not just ambisome or the ones that you're accustomed to. There's many preparations available across the world. The mechanism of action of amphotericin is very different to the azoles that we've been speaking about before.
Amphotericin is a polyene antifungal, and it exerts its activity by binding similarly in a way to the ergosterol in fungal cell membranes. But what happens with this is holes develop in the membrane, and this allows the cell components to leak out, which causes cell death. So in a way, it's a little bit like penicillins. So you may be aware of mechanism of action of penicillin. So it's very similar to that. Now, the leaking out of the contents actually means that some potassium and other small molecules can also leak out, which can lead to things like hypokalemia, one of the known problems with amphotericin treatment. We also need to bear in mind that you need to exercise caution when using different lipid formulations, as they're not interchangeable, and doses are not the same between different preparations either. Some considerations with ambisome therapy, because it can cause hypokalemia, and obviously then this can increase the risk of torsade de pont, which is literally translated as twisting of the peaks. This is an abnormal heart rhythm which can lead to sudden cardiac death. Another issue with ambisome is that it can cause renal dysfunction, and particular consideration needs to be given when patients are on other drugs that can affect renal function too, because all of the effects can be additive. Different formulations of liposomal amphotericin are not bioequivalent, so we cannot interchange between them. So for example, Abelset, the test dose is 1 milligram over 15 minutes, and then it's 5 milligrams per kilo once a day. Ambisome, the test dose is 1 milligram given over 10 minutes, but then the licensed dose is 3 milligrams per kilo once a day, but you can go up to a maximum of 5 milligrams per kilo. And going to Fungizone, this completely changes, and there's a very convoluted kind of dosing regime. So it's really important to look at the formulations available and then look at the dosing regimes that are needed for those formulations. Also, it's very important we don't interchange between these. It may be that the patient needs to be reloaded and baseline tests all double checked before you do change over. Just wanted to go over how to manage some of the ambisome interactions that we may see in practice. One of the examples I chose was amphotericin and acyclovir. Now, both of these drugs can affect renal function, and it's really important to pay particular attention when dosing people, perhaps with an increased BMI, a low BMI, so extremes of weight, and use ideal body weight, not actual body weight. There was a patient that I was managing, and he was a tall guy and weighed around 120 kilos. He was being dosed with acyclovir based on his actual body weight, and what we found was he went into acute renal failure because of the higher dose of the acyclovir, especially when given IV. When switched to ideal body weight, the dose was reduced by about a third and his renal function recovered. So it's really important that when patients are given drugs, perhaps one or more that can affect renal function profoundly, that we do monitor renal function very closely. So amphotericin and moxifloxacin. Amphotericin can cause hypokalemia, which increases the risk of sudden death due to torsade de pont. Now, these effects can be additive with drugs like moxifloxacin, because moxifloxacin can cause QT prolongation as well. Now, this is actually a class effect with all quinolones, so you can take any of the quinolones, and this perhaps is an issue with all of them. So the recommendation, perhaps, I would say, is to do a baseline ECG but patients do need to be treated with both of these drugs together. If another antibiotics can't be used or another antifungal can't be used, then baseline ECG is key, I feel. Also monitor potassium levels using these quite closely to make sure that everything stays within range, and you can act on anything if anything does derange, and you can do that quite quickly. Another drug perhaps that we may not come across so readily and know a lot about it are contrast agents, specifically gadolinium containing contrast agents. Now these agents can cause something called NSF, nephrogenic systemic fibrosis. Now this is a serious and life-threatening condition which is characterized by the formation of connective tissue in the skin, and it becomes thickened, coarse and really hard, which can lead to contractures and joint immobility. Patients with NSF can have systemic involvement of other organs as well, like the lungs, liver, muscle and the heart. So it's quite a serious issue that really needs to be given more thought. Now, managing patients who require ambisome with gadolinium containing contrast agents may perhaps feel a little bit challenging initially, but I think there's certain things we can do to if patients are needed to have both drugs at the same time. So firstly, I think monitoring renal function is key. And for those that already have renal impairment, patients that have severe renal impairment, then some of the contrast agents are actually contraindicated. So do double check which ones you can use and which ones you can't. Those patients that are perioperative around the liver transplant period, the use of high-risk agents is contraindicated. I do have a reference in the references section that you can go and check which agents are medium, low, medium and high risk. So these patients, high-risk agents are contraindicated. Some medium risk agents may be used if it can't be avoided, or a low-risk agent can be used. Neonates, the use of high-risk agents is contraindicated, and with breastfeeding, it is recommended that breastfeeding is discontinued for at least 24 hours after the use of a high-risk agent. In pregnancy, the use of any gadolinium-containing contrast agents is not recommended unless it would be absolutely necessary. So I think for these agents, if ambisome is required, then it is an evaluation on a case-by-case basis. There's no blanket rule that I can give you that you would use particularly for all patients. Look at your patient, look at the agents that perhaps can be used and the agents that may have a complete contraindication, and then take it from there. When patients are on ambisome and require drugs such as your aminoglycosides, gentamicin, amikacin, tobramycin. Now, I spoke about the additive effect of renal side effects being quite profound in some patients. And because ambisome and aminoglycosides can both cause nephrotoxicity, it is really important that they're used with caution if they have to be used at all together. If both drugs are to be used together, then there's a few points that you can make sure are adhered to so that patients are not harmed as a consequence of both of these drugs being used together. So I think one should be the patient is well hydrated, make sure fluids are kept up, and kidney function remains as well as we can keep it. Monitoring of the renal function goes without saying. It's really important that this is monitored very closely. Using ambisome or a liposomal amphotericin over other amphotericin preparations is recommended because these cause less side effects and can be tolerated better. If possible, monitoring aminoglycoside levels can be very, very useful. I know in the UK we have guidelines for monitoring aminoglycosides. In other countries, perhaps facilities may not be as readily available, but if possible, monitoring the gentamicin or the amikacin levels is useful, because it can tell you when the patient is in it has a toxic level. Now we're going to move on to echinocandins. These are synthetic derivatives of lipopeptides which are produced by various fungi. We've got 3 approved echinocandins: casperfungin, anidulafungin and mycofungin. Only parenteral formulations of these drugs are available, so no orals, only injections. And with regards to metabolism, they aren't processed by cytochrome P450, so less potential for interactions. However, liver function abnormalities are present in around 3% of people. So like with ambisome, we were talking about renal impact and additive effect of renal drugs. Well, here there may be a possible dual effect with other drugs that affect hepatic function as well, so it's key that we look out for these. So echinocandins work a little bit different to other antifungals that we've talked about. These inhibit the beta-D glucan synthase, and this prevents glucan synthesis. So this enzyme is not present in human cells, so there's no direct interactions related to binding sites. Hence, the first slide that I showed you, there's very few severe interactions with these drugs. I'm going to talk a little bit about how to manage interactions with echinocandins. We don't get very many severe interactions, but there are some that perhaps you may need to look out for. So echinocandins with carbamazepine and rifampicin, what we can see is carbamazepine is likely to reduce casperfungin levels. Even though it's a poor substrate for cytochrome P450 and not really a substrate for P glycoproteins, it is possible that the modest effect of rifampicin on casperfungin is due to the induction of tissue uptake transport proteins at steady state. So how we manage this is perhaps looking at when we're initiating casperfungin, if rifampicin or carbamazepine are being used, then actually increasing the dose from the loading dose from 50 milligrams to 70 milligrams. The US manufacturer states that the higher dose should be used anyway, so this is something that we should seriously consider, using the 70 rather than the 50. Something that we may come across with regards to using echinocandins, and something that we don't generally tend to look at or think of as a drug, is alcohol. If you look back to one of the first slides I talked about, it's not just about drugs, there can be food substances or beverages that we need to give consideration to with regards to interactions. Now, these two don't interact in the traditional sense, but both affect liver function. And this effect, again, is likely to be additive. So if there is somebody that has history of alcohol excess and does require treatment with an echinocandin, say mycofungin, then it is important to bear in mind already what the liver function is, what level the liver function is at, and whether there is concomitant drinking of alcohol at the time that mycofungin or casperfungin is given, and whether any dose adjustments are required to be made to do with liver function. Looking a little bit more at managing echinocandin interactions, I'm looking at cyclosporine and tacrolimus. Now, these drugs shouldn't theoretically interact, as casperfungin doesn't affect the cytochrome enzymes, and neither does it induce or inhibit. And again, it isn't a substrate for P glycoprotein either. But what we've seen in clinical studies is cyclosporine increased the area under the curve of casperfungin by around 35%. Now, these increases are probably due to the reduced uptake of casperfungin by the liver. Casperfungin didn't increase the plasma levels of cyclosporine, so the other way around doesn't seem to be much of a problem. What the other thing that was an issue as well, there were transient increases in liver ALT and AST of around threefold when casperfungin and cyclosporine were taken together, which resolved when the medicinal products were discontinued. So I think the take-home message is, if casperfungin and cyclosporine are to be used together, then monitor really closely and monitor the liver function and perhaps levels of the drugs. Cyclosporine levels are quite easy to monitor, and levels of the echinocandin if possible, just to make sure everything is within the ranges, the normal ranges that are, or perhaps the upper limit of ranges that is acceptable. Tacrolimus, when taken together with casperfungin, actually casperfungin reduced the trough concentration of tacrolimus by around 26% in healthy adult volunteers. So again, for patients that need to take both therapies, monitoring of tacrolimus blood concentrations and making those dose adjustments for the tacrolimus are essential, because what we don't want are toxicities of these drugs. So just look at some of these interactions may not theoretically be predicted and you may not think will happen, but it is important that we keep an eye on the few parameters that perhaps may need to be monitored when patients are taking such drugs. So again, following through with managing echinocandin interactions, dexamethasone is a drug that perhaps we've started using a little bit more, especially in the context of COVID and treatments that work. So especially in the pediatric population, dexamethasone and casperfungin, what we've seen from results from pharmacokinetic data is that we may get reductions in casperfungin trough levels, meaning that this can lead to treatment failure. Now, it is really important that we ensure we are dosing correctly. And in children, there's been a similar reduction as we see with inducers in adults when dexamethasone and casperfungin are used together. So it's really important that if these two drugs are used together, we cannot possibly use anything different. If the co-administration is unavoidable, then the dosing of casperfungin needs to be correct. So the literature actually recommends casperfungin dosing at 70 milligrams per meter squared daily. Now, as a pharmacist, dosing like this, we generally tend to dose in milligrams per kilo, not milligrams per meter squared. So you need to go a little bit further than what you're normally accustomed to, but getting the dose correct is really important and can mean the difference between treatment failure and not. Thank you for listening. And I'm hoping that with this presentation, you're able to take away perhaps a few points that even if in the traditional sense you may not have interactions predicted, there still can be some issues that you need the skills to be able to overcome. So please listen to the other presentations in this series as well, and I hope you find them all as useful.